Welcome to today's class. In this session, we'll delve into the definition, classification and pathophysiology of hypoxemic respiratory failure. We all know that the major function of the respiratory system is gas exchange. This involves the transfer of oxygen and carbon dioxide between atmospheric air and circulating blood within the pulmonary capillary bed. The respiratory system provides oxygen to and removes carbon dioxide from the body. The inability to perform either or both of these tasks results in respiratory failure. Moving on to the definition of respiratory failure. Respiratory failure is a syndrome in which respiratory system fails in one or both of its gas exchange function, oxygenation and carbon dioxide elimination. Respiratory failure is not a disease but a symptom of an underlying pathologic condition affecting lung function, oxygen delivery, cardiac output or baseline metabolic state. It is a condition that occurs because of one or more diseases involving the lungs or other body systems. Respiratory failure is classified as hypoxemic respiratory failure and hypercapnic respiratory failure. Hypoxemic respiratory failure is commonly defined as a partial pressure of oxygen less than 60 mm of Hg when the patient is receiving an inspired oxygen concentration of 60% or more. Hypercapnic respiratory failure is commonly defined as a partial pressure of carbon dioxide greater than 45 mm of Hg in combination with acidemia. Both of these are classified again as acute and chronic. Moving into the pathophysiology of respiratory failure. Respiratory failure is a syndrome caused by multitude of pathological states. We have seen that respiratory failure is classified into hypoxemic respiratory failure and hypercapnic respiratory failure. We'll see the pathophysiology of hypoxemic respiratory failure. In hypoxemic respiratory failure, 4 physiological mechanisms may cause hypoxemia and subsequent hypoxemic respiratory failure. Mismatch between ventilation and perfusion, commonly referred to as V/Q mismatch, shunt, diffusion limitation, and alveolar hypoventilation. The most common causes are V/Q mismatch and shunt. Let us see the first mechanism, that's the V/Q mismatch. Many conditions cause V/Q mismatch. The most common are those in which increased secretions are present in the airways, like chronic obstructive pulmonary disease, COPD, pneumonia, asthma in which bronchospasm is present, atelectasis, and pain. In all these conditions, there is limited airflow to alveoli but have no effect on blood flow to the gas exchange units. The consequence of this imbalance is V/Q mismatch. Second mechanism is a shunt. A shunt can be viewed as an extreme V/Q mismatch. A shunt occurs when blood exits the heart without having participated in gas exchange. There are 2 types of shunt, anatomic and intrapulmonary. An anatomic shunt occurs when blood passes through an anatomic channel in the heart, for example, a ventricular septal defect, and bypasses the. An intrapulmonary shunt occurs when blood flows through the pulmonary capillaries without participating in gas exchange. Third mechanism is diffusion limitation. Diffusion limitation occurs when gas exchange across the alveolar capillary interface is compromised by a process that thickens, damages, or destroys the alveolar membrane or affects blood flow through the pulmonary capillaries. Diffusion limitation is worsened by disease states affecting the pulmonary vascular bed, such as severe COPD. Some diseases like pulmonary fibrosis, interstitial lung disease, and ARDS states cause the alveolar capillary interface to become thicker, which slows gas transport. The fourth mechanism is alveolar hypoventilation. Alveolar hypoventilation is generalized decrease in ventilation that results in an increase in the partial pressure of carbon dioxide and a consequent decrease in partial pressure of oxygen. Alveolar hypoventilation may be the result of restrictive lung diseases, central nervous system diseases, chest wall dysfunction, acute asthma, or neuromuscular diseases. Hypoxemic respiratory failure is caused by combination of two or more of the followings: V/Q mismatch, shunt, diffusion limitation, and alveolar hypoventilation. Today, we have discussed up to the pathophysiology of hypoxemic respiratory failure. The remaining portion of this topic will be covered in the next class. Thank you.